Welcome back, everyone, to another monthly session of the MSM Journal Club. Today we have Numan. He's presenting on behalf of the Anesthesia Interest Group, discussing a case of propionic acidemia in the setting of a simultaneous liver and kidney transplant. So, without further ado, you can take it away and tell us all about this case.
Thank you, Izan, for the introduction. Hey, everyone. Again, my name is Mohammed Numan. Just a brief introduction. I'm a third-year med student at Morehouse and currently on my surgery clerkship. I have been very interested in anesthesia, and that's where I plan to go into. And currently, I'm the president of the Anesthesia Interest Group. So if any of you people are interested or have any questions, please feel free to reach me. I'll have my contact information at the end of the presentation. So today, as Izan mentioned, I'll be presenting a case on the anesthetic management of a patient with propionic acidemia undergoing simultaneous liver and kidney transplantation. So just to give a brief introduction about propionic acidemia.
Switch the screen you're sharing. I think it's showing the Safari tab that says click to exit full screen.
Exit full screen? Okay, let me exit full screen now.
There you go. Yeah.
That's good now? Okay, cool. Thank you. So propionic acidemia is a rare autosomal recessive inborn error of metabolism caused by deficiency in the enzyme propionyl-CoA carboxylase. And this enzyme is necessary for breaking down odd-chain fatty acids and several amino acids. And without this, with this enzyme missing, this leads to a buildup of toxic metabolites like propionic acid and methyl citrate. And this buildup can lead to some pretty life-threatening metabolic acidosis, especially during times of stress, any procedure like surgery, or any illness. And some of the clinical features of the buildup is hyperammonemia, encephalopathy, cardiomyopathy, and pancreatitis. So moving on to the case presentation. In this case, we cared for a 29-year-old woman with propionic acidemia who also had type 1 diabetes, stage 5 chronic kidney disease, congenital long QT syndrome, and developmental delay. Excuse me. She was admitted for acute on chronic kidney injury, and she ultimately underwent the combined liver and kidney transplantation. So because of her extensive history along with the already propionic acidemia, this was a bit of a challenging case to manage everything. So from the anesthesia perspective, the big anesthesia challenge here was preventing catabolic stress, which could trigger the acidosis or ketoacidosis. We used etomidate for induction to avoid propofol, which acted as a GABA A receptor and could have worsened the metabolic profile. And throughout the case, the patient was maintained on D10 insulin infusion to suppress ketogenesis. And later in the case, she had actually developed some rising lactate levels after we reperfused the liver. And so intralipid therapy was started intraoperatively to support some energy metabolism and kind of reduce reliance on the mitochondrial pathways for energy instead. And so this metabolic strategy was actually closely guided by the genetics team. And all the dosing and what meds to use was adjusted in real time with the genetics team included. So this is just a diagram showing the pathway, kind of explaining propionic acidemia and the underlying pathophysiology behind it. We could see here like this big red X kind of blocks out where the propionyl-CoA carboxylase would be. And it uses biotin as a cofactor. And it just takes propionyl-CoA and makes it into methyl malonyl-CoA, and et cetera. And so with this blocked off, it actually leads up to a buildup of the precursors. So propionyl-CoA, the odd-chain fatty acids, and et cetera. And what would happen, it goes downstream, leads to the accumulation of propionic acid, methyl citrate, 3-hydroxypropionates, propionyl carnitine. And this leads to the downstream effects: hyperammonemia because of the low N-acetylglutamates, the ketosis, the CNS depression. These are the main ones of note. So here we have the intraoperative timeline. I'm going to talk about the Y and X axes first, just to get everyone oriented. We have the Y-axis here that shows the lactate levels, which is in millimoles per liter. And we have the X-axis is just the time, the minutes since the induction, the start of anesthesia. So looking at the lactate levels first, they're in red. They rose from a baseline of around 2 at the beginning to a peak of 7.43 before kind of trending down towards the end of the case. So induction was started at 4:38 p.m. With the etomidate. And then we had a portal clamp and the start of the intralipid infusion at 2 grams per kg per day occurring at 7:30 p.m. Then we had the liver reperfusion at 8:38 p.m. followed by rise in lactate, And later on, we had a genetics consult at 10:47 p.m. due to concern of some metabolic decompensation. A urinary analysis was done to look for ketones, but it was negative. And the intralipid was then decreased to 1 gram per kg per day. So kidney reperfusion occurred at 11:23 p.m. And this is where we had the highest spike or the highest rising point of the lactate levels of 7.43. And then the decrease and the case had ended at 3 a.m. So this was actually a really long case. If you look at the breakdown of the times, it started at 4:38 p.m. and ended at 3 a.m. So almost 12 hours, just to show like how long and complex it was, probably for the surgeons. Actually, I talked to my resident that I had worked with, the anesthesia resident, Dr. Kevin Flood, and he wasn't even sure what happened afterwards because he was already off his shift before the case had actually completed. So going into the conclusion, this case highlights the importance of anticipating metabolic stress and building a multidisciplinary strategy for intraoperative management for patients with propionic acidemia undergoing surgery. The combination of the D10 insulin and intralipid infusions help prevent full-blown metabolic decompensation. But more broadly, the most important thing of this case is the reminder of how multidisciplinary cooperation is pretty essential in patient care, since genetics, anesthesia, crit care, and endocrinology were heavily involved in here. So that's the end of my presentation. Thank you so much for everyone for listening. I'm happy to take any questions. And here's my information at the end, my phone number and my email, if any of you guys want to know anything more about anesthesia or just any questions in general.